We're really delighted to have with us Dr. Peter Kramer to talk about his new book, Ordinarily Well, The Case for Antidepressants. You know, the role of psychopharmacology in treating depression is, of course, a controversial issue, and Dr. Kramer has been a key voice in that debate. He's a practicing psychiatrist and a faculty member at Brown Medical School who rocketed to fame more than 2 decades ago with his best-selling book, Listening to Prozac. Concerned a bit about being tagged for life as Dr. Prozac, Dr. Kramer, who does have diverse interests, has spent a good part of the past 20 years writing and speaking on other topics, including depression more generally, intimacy, domestic violence, and neuroscience, and he also wrote a novel. But he decided to weigh into the argument over antidepressants again because he couldn't ignore the persistent assault on such chemical treatment. With 1 in 8 Americans now relying on these medications, this is clearly a huge issue for many people. In his new book, Dr. Kramer closely examines the drug studies and hard science, but he also devotes some of his most engaging chapters to describing his own experience treating patients. In the prologue, he characterizes the book as both his most technical and his most personal. Overall, he makes a persuasive case that both psychotherapy and antidepressants have roles to play in combating depression, and what's key is a case-by-case approach to treatment. A review in Kirkus said Dr. Kramer's book is, quote, written with the compassion, verve, and style that are the author's trademark, and The Atlantic called it, quote, an ambitious, persuasive, and important book. Dr. Kramer will be in conversation here with Judith Warner, herself an accomplished author, whose best-selling book, Perfect Madness, a decade ago looked at motherhood in the age of anxiety, and whose more recent book, We've Got Issues, examined the use of drugs in controlling the behavior of children. So ladies and gentlemen, please join me in welcoming Peter Kramer and Judith Warner.
Thanks so much, everybody, for coming out tonight. As we were saying beforehand, there's some pretty stiff competition in terms of speakers tonight, so it's great to see such a good crowd. Peter, just to jump in right away, you've been writing against the current, in a sense, for a long time now when it comes to antidepressants. And on the one hand, it seems odd to have to make the argument that they work, and yet you've had to make this argument over and over again here at greatest length. And you said to me once years ago that making this argument and in a sense being on the same side as the drug companies and doing so was like being a Republican. Yeah, I figured this was the right crowd for that. And you've said to me earlier tonight that it's very pleasant, was the word you used, for people, journalists in particular often, to believe and to put out the story that these medicines don't work. Why is that?
I do think that in a funny way I write against the grain, and writing this book and more lately speaking about it has made me aware of that. I think we are uncomfortable with the notion of depression being a medical illness, even as a predominant way, if not the exclusive way of thinking about it. The idea that melancholy is informative or noble in some way is so culturally ingrained, so natural to us. I think drug companies have behaved badly. It's very hard to be on the same side as drug companies, even if they have provided these extraordinary tools. I mean, to think what has happened, that we now can treat this illness fairly straightforwardly, and for millennia, people were searching for treatments and there weren't any. I mean, for 50, 60 years now, we've made some inroads against depression. I think medical psychiatry in general is in a hard place. The notion that we can diagnose things, And you know, the sort of things you write about with attention deficits or anxiety in children, you know, the notion of putting those things in categories and treating them medically doesn't seem like the liberal or humane posture. So, you know, so and I don't think I've listed all the reasons, but I think culturally we're just uncomfortable with the notion that there might be some straightforward way to interrupt these ailments, and there's something eerie about it, something eerie about applying technology to the problem.
Even before we get into sort of deconstructing the pushback, you start this book, which is a pushback against antidepressants, with a kind of mea culpa, as though you see for yourself some part of responsibility in the current arguments against SSRIs. Why is that?
You know, I actually think one of the reviews clarified this. It was a very good review by Scott Stossel of The Atlantic in the New York Times Sunday Book Review. And he said, I had written in listening to Prozac about ideas like better than well, that patients who had gone on these medicines would come in to me and say in the late 1980s, you know, I didn't just get over the episode of depression, I'm more confident, I'm more assertive. And one of the early reviewers of that book in the LA Times said, this is really a book that could have been called Worrying About Prozac. It was, the shorthand straw man view of this is that it's pro-medicine, but the content of the book really is worried. Would we overuse the medicine? Would we stretch the diagnosis of depression because people like being more assertive, the cultural rewards it, and so on? And I think as this other argument that the medicines are not appropriate treatments, say, for straightforward depression. I hope you know a little what depression is. We can kind of backfill and say something about that. But I didn't want to be responsible for people mistaking that message about overuse for a message about use, because I think these medicines actually are very important in the treatment of depression.
Just to stay with that for a moment, the thought that maybe you need to backfill a bit about depression, you do write about it in an extremely humane way and also in a very passionate way in making the case, for example, in your book Against Depression, how devastating an illness it is. And just the way you describe it flies in the face of the way the people who make arguments against Prozac and other SSRIs describe it. So it would be helpful, actually, to share with people who maybe haven't read all of your work what you see in the office and what you think of when you think of depression.
Right. So depression is a very varied ailment, and I don't know that I sought out depression. In an odd way, it seems like depression found me. I wrote listening to Prozac, which I thought was sort of a book of cultural commentary. It was about our coming more and more to believe that personality has strong biological contributors and so on, and how that fit into the history of our understanding of ourselves. But because I wrote that, more and more depressed people came to me, and I found that I enjoyed that shift in my practice. And in another book, Against Depression, I write about my family, which is what's now called Holocaust survivors. They weren't really Holocaust survivors. They were immigrants because of the Holocaust, but with many family members lost in the process. And there was probably some mood disorder in the earlier generations, and I think I found myself very much attuned to it. But depression is something that has changed over the course of my career. And in this book, I write about what depression looked like in the 1970s when I was in medical school. And then on the medical wards, you would see people who look like, you know, medieval Renaissance etchings of depression, these thin, asthenic, tortured souls, people sitting in bed, wringing their hands, repeating negative thoughts, and they were just depressed. There are all kinds of things that can be confused with depression, neurological syndromes, and their depression accompanied by psychosis has its own problems. But there was straightforward depression looked like that, and the kind of question that doctors would ask when someone was depressed was, well, how many notches has he tightened his belt? You know, people would really almost starve to death of depression, We don't see that now. We don't see much of it. There's some dispute about that, but I would say we see much less of it. And I think we see less of it because we interrupt it. And this is a whole discussion in psychiatry about what depression is. Is there some separate kind of depression that has that path, or does all depression? But I think the best studies of genetics and so on say that ordinary depression that looks sort of neurotic, it looks like a personality style, if you have enough episodes, if they get longer and more closely spaced, start taking on this very biological quality, so that really it looks, even though it may be like autism, that there are going to be 1,000 genetic contributors to it, the syndrome has a sort of, to my mind, a sort of unitary quality, and involves these symptoms that we're familiar with. People are sad, they're apathetic, they don't experience pleasure, they have trouble with sleep and appetite, they may be suicidal, they have trouble with energy, concentration, memory. And I think it's such a common syndrome that you've all either experienced it or known people who have experienced it. And one of the really important aspects of it is that it interferes with quality of life. And setting aside everything else that's in this book, and there's a lot in this book that critiques or praises aspects of the studies of antidepressants, one of the most impressive things is that when people have looked at quality of life using measures that weren't created for mental illness at all, they were meant to distinguish between which blood pressure pill is giving you too many side effects and which one is allowing you to live well. If you look at the quality of life measures, every study that's looked at this says that depressed people, when they go on antidepressants, have an improved quality of life. And in a lot of the studies, they have the same quality of life once they've been on medicines for a while as their neighbors who've never been depressed. So, and that, of course, is in psychotherapy largely what we're dealing with. It's not, we're not trying to pick off symptom by symptom, but get people able to go to work, parent their children, enjoy their marriages, and so on.
So the depression that you're writing about is a very serious illness, even if in its mild forms, with very, really big effects on people's quality of life. But the phrase that became attached to you was cosmetic psychopharmacology. Have you actually ever seen any evidence of cosmetic psychopharmacology being practiced?
I have not. I've not seen a single case. So this notion was modeled on cosmetic surgery. The idea was that you could, take a burn victim and do reconstructive plastic surgery, or you could take someone who is perfectly normal but has an appearance that is less socially favored or less favored by that person, less culturally rewarded, socially rewarded, and use plastic surgery for that, to that end, and that was cosmetic surgery. And that my concern, having seen Prozac work in these patients who came back and said they were more assertive, was if we were able to, and this was theoretical, would we be prescribing for normal people to move them from one normal, less rewarded, less desired state to another state. And I have to say, I see, of course, I have a very privileged practice. I'm not treating people who come out of Medicaid mills, or I'm not working in nursing homes. I'm working, largely the doctors who refer to me I think are good doctors. So I see a lot of good doctoring. Even though I might say I might not have medicated this patient or I do it differently, I've really never seen a case where I thought, this is a person who doesn't have some condition really worth treating. I just haven't seen the trivial use of medication.
And yet that concept is so popular in academia. It's so popular with philosophers, with sociologists, and the notion of enhancement generally has had a big run. I mean, it's a trope that shows up all the time in discussions of ADHD and stimulants and, in that case, cognitive enhancement. Why do we love that concept so much? Why does it have a kind of a reality in our culture that goes far beyond its reality in clinical practice?
Well, I mean, I have to say I'm to some extent responsible. I think I energized that field of medical ethics, having to do with enhancement. I think we do worry about technology over flowing its bounds in all kinds of ways, so that medication is just one example, and that, you know, Prozac came along not long before Viagra. It came along about the time that there were medicines that seemed possibly minoxidil, I think, to grow hair. And so there were sort of hints that a lot of the pathology, and I think also the nature of research in medicine was becoming more related to receptors, genes, and since there's enough overlap between what determines illness and what determines normal states, it was fairly clear that we ought to be thinking about that potential. So I'm not sure I would say we oughtn't to be thinking about it, but I do think we oughtn't to be saying that practice is going on without probably better evidence that it is.
You may blame yourself a little bit too much, because one thing that you do show in a really interesting way in this book is that the resistance to antidepressants goes back as far as antidepressants themselves. So it goes back to, you know, imipramine came along, I think, in 1961, and then there was a big influential article arguing against it, even though it was enormously effective in 1965, and then the story sort of goes on from there.
Right,
Can you
right.
talk about
No,
that,
the
and
dates
also
are,
how it's changed maybe over time?
Yes, I mean, this is someone named Robert Lieberman very generously has shared his story. He's an important psychiatrist who's done a lot of work with very troubled patients and work in community psychiatry and so on. And he was a medical student at Dartmouth in 1961, and I guess with the encouragement of his professors, he wrote an article effectively attacking psychotherapeutic medication altogether. Now, these medicines had first become available in the late 1950s, and however well or poorly they were tested, they were the best tested medicines in all of medicine. Later, when the Kefauver-Harris Act was written, and the FDA was given authority to demand that medicines be effective, that legislation was based largely on research on psychotherapeutic medication. That was the model of the research. So these were the best tested drugs, and in the early 1960s, Lieberman said that imipramine, this early antidepressant, was probably no better than placebo. And he then transferred to Johns Hopkins, probably on the strength of having written a published article, and it was more stressful. He became depressed, was given an antidepressant, he got better. And the story sort of continues from there, where he keeps resisting this awareness, goes to NIMH, gets depressed, gets put on an antidepressant, gets better, goes to California, gets depressed again, is treated with psychotherapy. The doctors are very opposed to medication, goes to England, comes back a wreck, he gets ECT. I mean, this is a progressive disorder, and finally became one of these first doctors to be open with his patients and say, look, I'm on medicine, I need the medicine, you should be taking your medicine. So this story about placebo, you know, occurs before there's any research suggesting that these medicines have placebo effects. And there's another, I'm not going to tell the story, but a wonderful paragraph that a woman wrote about the antidepressed personality, which is just devastating, you know, until you realize that she was writing this at a time when almost no one was on antidepressants. She was writing it at a time when very different medicines were being used. So this wish, and I think it largely is it partly is doubts about science, it partly is protection of psychotherapy. This placebo argument long precedes our current type of evidence about it. And then, you know, this is another discussion. I think that it's not just in popular journalism and 60 Minutes and so on that people want to hear that these medicines don't work, that even in the professional journals, these articles that have been published that seem to show that antidepressants are no better than placebos really use a level of science that seems to me, you know, it's sort of jaw-dropping to start seeing what the flaws are in the research, you know, why it got accepted and published in respected journals.
Well, let's talk about that now, because that is the bulk of the book, is walking through all of these studies and walking through this argument, really taking it apart. Probably everyone in this room has read at least one of the articles that made the case. There were a lot of them in 2010, 2011, antidepressants don't work, Newsweek, a bunch of other places. And you really walk through the flaws in that argumentation. And can you sort of boil that down for us?
I want to just give two examples. One is an article from 1998, which was clearly meant to be provocative. It was so provocative that it was published along with critiques of it. And it was called, the main title was called The Listening to Prozac But Hearing Placebo. So it came to my attention immediately. And I didn't comment on it because I thought it was really bold and funny and obnoxious. And I thought the drug companies and these researchers needed to be twitted a little bit. But in the critique, Donald Klein, who is a pioneering psychiatrist, pharmacologist, he doesn't like to be called a psychopharmacologist, but he is, he called one of the arguments the trout in the milk. Now, this is a wonderful metaphor from Henry David Thoreau. In the late 1840s, the dairy farmers went on strike, and the delivery men were accused of watering down the milk. And Thoreau said, he was talking about circumstantial evidence, and he said there's some circumstantial evidence that is highly convincing, as when you find a trout in the milk. So this was the trout in the milk, and the idea was that this researcher had not gotten bad enough results for antidepressants. So he said, well, we think the remaining results, the remaining benefit of antidepressant over placebo in these controlled trials is due to the fact that the placebos aren't convincing enough. They don't have enough side effects. So we looked for medicines that really don't treat depression, but that have side effects, but that have been used in treating depressed patients. And we found that they worked as well as antidepressants. And the example, the trout and the fish, was lithium and thyroid hormone, which PS, aren't so much not antidepressants that should impress anyone. But in the study quoted, they were given with full doses of antidepressants. So that was the trout in the milk. Of course, the result of, they were being compared, this augmentation with low-dose lithium and thyroid was being contrasted with full doses of antidepressants, so that in this study, in the placebo category, in the data that was talking about how well placebo worked, in this case, the patients were on full doses of antidepressants. Those were the patients on placebo. So it just seemed like this researcher wasn't trying to, that this was circumstantial evidence that this was sort of a put-up job, I guess, is what Donald Klein was implying.
So you have other examples also of sort of systematic flaws in the placebo argument, and they sort of fall into different categories of problems. One has to do with who is participating in the drug trials. Can you talk about that some?
Yeah, no, this is the biggest problem with drug testing is finding representative populations. And the reason is that these drugs work. So that if you have straightforward depression, and it's your, say you've been somewhat affected by depression, now you're really badly affected, and nothing's working, and you're put on an antidepressant, no one's going to put you in a drug trial because there are perfectly good medicines around. So that the people who go into drug trials are, in the book I actually went to one of these commercial research centers where drug companies send their patients to be tested, and I went out in the van, and the van went to this inner city and picked up people at single room occupancies, and these were people who clearly, from the conversations with each other in the van, had been in a lot of drug trials, and they were giving each other encouragement, and the most important thing in their day was going to the drug trial, and the van would bring them to their welfare to work course at the junior college after the conversation with the raters. And so, what's going on in the drug testing doesn't seem reliable. Actually, let me back off and say something. This is, I'm not sure all of this is in, I guess this is in the book, but what do you think the odds are if you have the kind of depression I said, you have a straightforward episode of depression, it's your first or second time being treated, what are the odds that you'll get substantially better on the first medicine you're given? And when I ask groups this question, they say very low. And lately, there have been a number of articles, and some by very thoughtful psychiatrists, saying that the response rate is about 30%. Well, that number comes from a famous trial, large trial, sponsored by the NIMH, and the people in that group had been depressed for 15 years. And this was meant to cover the range of depression, but this is who showed up. They'd been depressed on and off for 15 years on average. They were on average in their 7th or 8th episode. The current episode had lasted 2 years despite treatment, and they mostly were, in addition, either alcoholic or subject to some other mental illness beyond depression. And those people had a 30%, not a 30% response rate, a 30% remission rate on the first drug they were given. They left the episode of depression on the first drug they were given. So to me, that's high efficacy. And if you look at studies of people in primary care practices back in the days when you could get primary practitioners to enter these trials and just give people medication, the response rates are more like 75%, and for people who actually complete a course of treatment, 90%. So, these are much less complicated depressions, but it just is very hard to do drug trials now. And the NIMH trial is very favorable in terms of the population compared to people who would be in a trial for a new drug that had, not yet come to market.
You also talk about the ways that even how depression is measured, let's say, the rating scales that are used in trials, create problems then in terms of our ability to judge what's placebo and what isn't, and the definition of depression as well that could be used differently.
So one of the things I try to do in the book is think about evidence. What's evidence? Because we're in the era of evidence-based medicine. There's a lot of intolerance for doctors kind of going with their gut, and or which is to say using their experience and experience of their colleagues. And I try to think about how evidence-based medicine applies in psychiatry. And the rating scale, the standard rating scale, the one that's used most often, was developed also in the late 1950s and the 1960s. It was grabbed onto by drug companies in part because it gave a lot of points for dealing with insomnia, and the early drugs were sedating, so they got a little help from the scales. But the scale has, in the most popular version, 17 items. You can get 2, 3, 4 points on each item. And it turns out that scale has wandered from the earlier way it doesn't correspond well to the earlier way of judging depression, which was just doctors had some gut feeling that this person was, not functioning well and was very sad. And so a Danish group came back and asked doctors, who's depressed, how depressed are they, just talk to us. And they found that 6 items on this scale, that if you had a 6-item scale, you did much better than you did with a larger scale. Well, later, these newer antidepressants like Prozac and Zoloft and Lexapro came to market, and it turns out they do much better on the 6-item scale than on the 17-item scale. That part of our ability to say that placebos do very well, in contrast to antidepressants, has to do with having a scale that has lots of items like stomach upset and constipation and insomnia that, wax and wane so much on their own in people who are not very depressed, that when you put together these bad populations and have a sort of scattershot collection of symptoms being measured, it starts being hard to see the drug effects.
Overall, the impression that you get from reading really all the detailed analysis of the way drug trials are done is that drug trials are a disaster and that things are getting worse. Why is that?
I think drug trials are able to do one thing, and that we can be grateful for it, which is they can sort of say yes or no. Do these, is there some signal? Do the drugs work? Should we give doctors a try with these medicines? And honestly, there have been antidepressants that have come to market that doctors have just decided aren't that effective and weren't successes. So that there's some crowdsourcing of the evidence after these drug trials. But I think it's just folly to think that we have exact numbers that tell us how well medicines work when there aren't patients to test. I think that one question of enrollment, whether there are patients to test them on, is the worst. But there have been scandals. I mean, not clearly, but it seems like it was harder to get negative trials published than positive trials, that the drug companies were trying to hold back the evidence, or early in the course of a drug's development, if a drug didn't work, it wasn't big news, and the professional journals weren't quick to pick it up. But for well over a decade now, we've had pre-registration of trials, and all the data's out there. And I think part of what I do, as in pointing to this Danish method of using fewer symptoms, is to ask how researchers can get good evidence out of flawed data. And I think there is enough good evidence that it doesn't seem to me a mystery whether these medicines work, and whether they work well. I think they work quite well, actually.
Part of the problem is, though, that people don't believe the evidence, and that's partly because of the practices of the pharmaceutical industry, the marketing practices largely, that we've read about. How could that be fixed? How could confidence be restored so that if there was good data, people would actually believe in it? And how would you make a change to get good data in the first place? How could you have, let's say, a neutral body?
Right. It doesn't seem to me a given that drug companies should be evaluating drugs. You could dun drug companies when there's a successful drug for aftermarket research. You could dun them for having neutral agencies test the medications. It doesn't seem to me on the face of it, that method, that way. Of course, these trials are enormously expensive, so you'd have to, let me say something about the opposite problem, which is the drug companies have fled mental health research. There just isn't any money. That as the FDA began demanding more, as critics started pointing out scandals, the drug companies simply left the field. So the problem is that now you have sort of garage band research. There are lots of interesting ideas in depression treatment now, but there isn't the funding to do them. So the question is, what would you do with a startup that had you didn't really need public funds to test drugs?
That was going to be my next question, but I guess the likelihood of public funds is ridiculous.
Well, we have to change. We have to make big change in this election, I guess, before there are going to be public funds for anything.
Just curious to know, just steering a little bit away from the book itself, although you get into this a bit, what kind of role will genetic testing be able to play in all of this as time goes on? What's most exciting on the horizon?
Right.
Will we get to a phase of personalized medicine where some of these questions will become moot conceivably?
Right. I mean, there is gene testing for antidepressant responsiveness. So you can send your blood off to the Mayo Clinic, which is the big proponent of this, and slightly increase your odds of knowing, which drug will work for you. The very best result I've seen is about a 1 in 12 result, so that if you did gene testing on 12 people, you'd get 7 responses, where if you just randomly gave the drugs, you'd get 6 responses, that sort of thing.
Meaning you'd get a better response to the drug, or you'd get a response from the testing that would let you know which
you wouldn't have to try one drug and then try another drug, but the help you'd get from that information is fairly slight. But it's much improved. It used to be 1 in 50, so 1 in 12 maybe is a little. It's almost at the level where it would pay for an insurance company to have you have the gene testing. But this testing is fairly indirect. A lot of it has to do with whether you have enzymes that will make you break down the drug too slowly or too quickly, so that you might get a lot of side effects or might not get a lot of main effect. In terms of really testing whether something is going to work for you based on its main method of efficacy, we're still not there. And I really wonder whether when we get there, we won't have other drugs entirely. I mean, it seems to me that those things ought to go together, and that it won't, it may never be the case that it will be very important to do gene testing for these very drugs. Although I will say the whole question of these drugs being a lot like placebos will go away once we can do that, because if you could have a pretty good hit rate, it would be entirely obvious that the medicine was directly affecting the person.
I'm just going to ask you one last question, and then we'll go to audience questions. You said that this book was your most solitary. Why? What do you mean?
I don't know. I don't remember solitary, but this book certainly has been different. It's a message book. It's an argument book. I like to do things where I take a small question and it resonates outward. Should you leave? It's about a relationship that, really where it's a close call. And what does that tell us about our understanding of intimacy, our ability to comment on close calls, and really sort of culturally coming to terms with how important divorce is in marriage, how important the possibility of divorce is. I think this book, I just had to, because this book would not be convincing if it weren't convincing, I had to really go into the research and find things that nobody has commented on. I mean, in this book, I'm really sharing research analysis with the public that has never been shared with fellow professionals. It is just, I think the field accepted some of this research on its face when it shouldn't have. But I think I also was saying that this book is very intimate to me, that it just mattered. It mattered for my, patients would come in and say, patients whose lives had been transformed, right? Their marriage had been saved, they were doing better with their kids, and they'd say, should I go off this medicine? I understand that it's just placebo. Am I just imagining that it's helping me? And my jaw dropped. Not that we wouldn't all the time or at any point happily discuss whether it's time to come off the medicine, but coming off it because it wasn't doing anything seemed to me just not plausible at all. And I start the book with a story which is in a sense neither here nor there, but was really the motivation for going back and writing this book, which was I had a friend who had a stroke, and it was the kind of stroke where if you gave medicine like Prozac early, you had a chance of restoring motor function. That it turns out that these medicines, not only aren't placebos, but they're sort of tonics for the brain in a scattershot way, that they help the brain resume making new cells in parts of the brain where adults make new brain cells. They help the neurons make new connections between cells. And that's helpful not just in depression, but in things like some post-stroke syndromes, although they're also happen to be very helpful in preventing depression in stroke survivors who are very vulnerable to depression, both on a psychological basis and a neurobiological basis. And when I spoke to my friend's neurologist, he said, well, I've really cut back on prescribing those medicines because of all this information that they're really not effective. And I thought, this is so clear. This is really time someone has to speak up and say, enough is enough.
Well, I think that's a great place for us to break, and I'm sure that people have questions for you.
Yes, Dr. Kramer, is there any evidence or concern that the current most popular antidepressants can cause damage to brain cells, and also how addictive are the current antidepressants?
Right. So, there is lots of concern. The question is, do these medicines damage brain cells, or are they addictive? And I don't think that they're damaging brain cells, but the addiction question is a very complicated one, right? Because people become psychologically addicted. People have benefits that they have trouble doing without. So that these drugs are not classically addictive. People don't crave them. They don't, want ever higher doses. They don't have a lot of street value and so on. But the drugs can be hard to come off. I write actually a fair amount about this in the book, and it's sort of a complicated question. But what complicates it is precisely that the medicines work. So that if, there are lots of studies of what is called maintenance. So say you have had a number of episodes of depression, or you've been very suicidal, your doctor decides to keep you on medicine for a while, and how much protection are you getting from staying on medicine as opposed to coming off medicine? And it doesn't matter what interval you study, whether it's weeks, months, or years. It seems like people have 2 or 3 times as many depressive episodes if they come off medicine than if they stay on. And then there's lots of dispute in the field about what this means. Did the medicine just postpone depressions people were going to have anyway? Is there some enhancement of the liability to depression so that when people come off, they are more liable to depression than they would have been if they hadn't gotten medicine at all? And I mean, my answer to all those questions is really on the more optimistic side, but they are under dispute. And some of what I get into the book are the fallacies in the research that show bad effects. Now, I'll mention one of the fallacies, which is if you compare people who did well on placebo with people who did well on medication, and you then either continue the people on placebo or take the people on medication and put them on placebo, the people on placebo will do better. Well, why is that? And this fallacy, this statistical fallacy, is called the differential sieve. The differential sieve is like this. Placebo is a narrow sieve. If placebo does nothing, if it isn't the case, as people who favor placebo say, that placebo is making people better, that placebo is like a drug. If placebo does nothing, you have to be very naturally resilient or healthy to do well on placebo. So that people are coming, so only those people are coming through the sieve. Whereas if medication helps people, the people who get better on medication include naturally resilient people, but they include lots of people who really need the medicine. So that's a broader sieve. It's letting through a much more diverse group of people. So if the medicine works, we ought to expect in that comparison then that there would be more relapses in the group who had done well on medicine. But the comparison, that is to give the argument more credit than it deserves, because the comparison isn't even that good, but I won't get into that.
Oh, I'm so sorry.
Okay. I wanted to highlight the one aspect of using these antidepressants, which I think has been very much left out. When I look for side effects of these medications, I find it's not easily come by. I mean, the whole world of side effects of our medications, I don't know who's responsible, whether it's government agencies, but there's a real dearth of information on side effects, and I think it's a very bad problem, and I'd like your comment to, what do you think are the best resources available to us now, reliable resources or evidence-based resources on side effects?
Well, I mean, the question is whether side effects are sort of underplayed in the literature. I just think there's an enormous literature on side effects. And I mean, my own experience is that I'll get reporters will call me and they'll say, what about this side effect? England is the great source of outrage about side effects. In England, such and such side effect has been reported. And I'll say, I sort of scratch my head and say, I think I read about that side effect before the drug ever came to market. I think that one's in the literature, and I'll go back and it will, it's almost never that someone comes up with a new side effect. And there are, some of these side effects are just very hard to suss out. There was some concern that antidepressants caused falls. And I think that's certainly possible. And the elderly, people who are on almost any medicine are likelier to fall, suffer a fall and break a hip or whatever than people not on medicine. But somebody went into the literature and found that the yes, there were falls in conjunction with the giving of antidepressants in nursing homes, but if you broaden the scope to look at before and after, that it was an equal increase in the falls before the antidepressants were prescribed. That it was, that it was something going wrong with the person that led to the prescribing of the antidepressants. So, you know what I mean? I think some of these are just difficult, and whether there's difficult problems. But in my experience, if you're a doctor and you're worried about side effects, there is a lot of aftermarket reporting, and I mean there are particular problems. What is suicide? There's a very controversial study about Paxil and whether the drug company recognized enough suicidal ideation or suicide attempts in the lead up to the marketing of the drug. But if you read the article, I mean, you kind of scratch your head and say, was that a suicide attempt or wasn't? You know what I mean? It's not, yes, the drug company could have done better, but on the other hand, it's not like your jaw drops and you think, oh my God, they were hiding this enormous propensity to suicidality.
You make the point in the book that we bring a demand to psychotropic medications, a level of demand that we don't to other medications in terms of side effects, also in terms of efficacy, that we look at them differently.
No, it's entirely clear that the FDA was very interested in suicidality in these medicines, and actually issued a black box warning saying that doctors should be very hesitant to prescribe certain medicines for children and adolescents, and had to watch carefully because they might get more suicidal ideation, and that seems to be true, although there were some studies subsequently that as doctors cut back on their prescribing, there were more suicide attempts in adolescents. So these medicines clearly are protective as well. But once the FDA started looking at this, they found these in medicines for epilepsy also, and nobody had ever talked about that. I mean, people just weren't worried about the anti-epileptics in the treatment of epilepsy. So that it's just clearly the case that our worries about psychotherapeutic medicines are of a different sort than our worries about, and the anti-epileptics have been around forever for other treatments. And so one of the core questions, the stigma questions, is, do you think of mental illness as illness? Right. And there's a sense in which this literature doesn't do that.
Hi. So my question is a little bit about sustainability of the effects that antidepressants might have, because I know a lot of studies will find that the most effective treatments are a combination with behavioral therapies. So I was just wondering how you've seen the effects of antidepressants alone in terms of somebody's ability to be resilient or to cope with new challenges versus just attempting to recover from one episode.
I mean, I have probably the answer you don't want to hear to this. This is about the difference between medicine and psychotherapy in combination. And discussing evidence in the book, I say, look, my practice isn't really evidence-based in this sense. I like to give everyone psychotherapy. It's very hard to get into my practice if you're not willing to be treated by me in psychotherapy. That's where we start. And medicines come later, unless it's really urgent, or unless people come in, they're already on medication. And I like to combine medication and psychotherapy. But if you really look at the evidence, the way people look at the evidence for drugs about combining medicine and psychotherapy, the evidence isn't that good. We kind of know it's good. It seems logical that it's good. People need guidance. It helps to make hay while the sun shines. I like people to rework relationships, be able to rework relationships, know that they're not as vulnerable as they were and that they can take other risks. So it makes all the sense in the world to combine these. But the research just isn't that good. And this also leans into verges on this question of journalism. So there was a fantastic study that was out of Penn, Rush, and Vanderbilt, where what they decided to do was see, how well does the practice of pharmacology work. So they took people very similar to the ones in the other study I mentioned, people with chronic recurrent depression, very severe depression, sometimes largely. And they said to the pharmacologist, just do your worst, raise the dose, change medicines, add a second medicine. We want to get these people into remission. What does it take to get people not to be depressed and stay not depressed for 6 months? So that was the challenge. But they also gave half the patients cognitive behavioral psychotherapy, and not just a little. It was weeks and weeks until they were better, sometimes twice a week. And the press reported the result of this study that cognitive behavioral therapy is a really important adjunct to pharmacology. That was literally what the press was reporting and what the researchers themselves were reporting. Well, it turned out that was true for a quarter of patients, that people who had acute, severe depression benefited sort of prophylactically from early psychotherapy. And the other 3/4 of patients, the psychotherapy did nothing. And in some of these subgroups, people seem to do better on medicine alone than they did on medicine and psychotherapy. So we just don't want to believe that. We don't publish evidence on it. And P.S., I think it's wrong. But if we're really going to say we're evidence-based, we would say, just let the psychopharmacologists do their worst. But the reason that's true, I think, is that they do really well. There's just not that much headroom. That if you let people really work at this problem, and the same might be true if we let psychotherapists do their worst, that pharmacology would find little headroom. But anyway, so the answer is I believe in it, but I would say if we're going to say meds aren't that effective, we'd really be hard-pressed to justify psychotherapy.
Hi, thank you very much for your other books as well. I loved Against Depression. That was really a big, wide open door. I've had it in my family. I just need to say I was so surprised by the question, are these medications addictive? Do we ask those questions about medication that is life-saving for, say, diabetes? It doesn't matter if it's addictive or not, if it's saving lives, but that's not my question. My question is actually, I've read your book already, and I'm hoping to have a shortened version. I know someone who has grappled with depression and has bought hook, line, and sinker all the arguments about, this is placebos or the pharma companies or whatever, and who doesn't want to at all take those risks. What's the short pitch?
Well, yes. So this is an obsessive book, right? When I started looking into this, I really started looking into it, and I hope it's fun. To me, the details are fun, the different perspectives, and the chapters are very short, and they alternate storytelling of my own practice, history, my own medical training, and these sort of more statistical chapters. But it is, whether it's a beach read, I can't say, but I will say that nowadays when you write these books, you used to go on book tours to wonderful events like this all around the country. Now you're kind of stuck in a closet, and Utah Public Radio or something is speaking to you. But in addition, you're asked to write all these 800-word blog-type articles about your book, so that there are out there, for my sins, various sort of short versions of things that I've written.
Not too short version that you wrote for the Times Sunday Review section a while ago.
Right. 5 years ago, I wrote, when the Sunday Review was just beginning, they asked me to write an article, and I chose this topic and wrote about this. But I think it's not as accurate. I know a lot more 5 years later, so I'm not sending people to that. But it does make some argument.
So there's a request, because we're running out of time, that we need to keep the questions relatively short, and so we can get to everybody.
Noting a lot of institutions push cognitive behavioral therapy, do you think there's a desire to use CBT as a substitute for medication?
Yes, I mean, I think cognitive behavioral therapy, we can go into what this is sort of the therapy of the moment. I think it's the therapy of the moment, or maybe it's a moment, it's a little past, but it's almost the therapy of the moment, because people who like it, it's a very rational, teaching-centered therapy, are also the people who like to do research. So there's been a lot of research on it. There's a wonderful book by a guy named Bruce Wampold out of the University of Wisconsin called The Great Psychotherapy Debate that really takes on the studies and says what matters in therapy is the doctor-patient relationship, the therapeutic alliance, having some effort in common, and that CBT doesn't outperform the other therapies. And there are these funny results that he points up where, you know, there's a cognitive therapy for marriage where, you know, the people got much better at discussing their problems and the divorce rate increased. I mean, it was, you know, it's like you have to always sometimes look one step farther. So I'm not an enormous fan of CBT, but, you know, I'm a fan of psychotherapy, and I don't think it's worse than anything else.
Okay, sorry, kind of short here. I have a comment and a question. My comment is just that I think, like you, I think of depression and I also think of anxiety as illnesses. But do you think of it based on your research and your own practice? Do you think of it as an illness like strep, or do you think of an illness like diabetes? Because if we think of it an illness like diabetes, there's really no reason that you have to go off of it. You're not going to go off that kind of med.
Right. So yeah, I mean, it's clearly this is a recurrent, progressive, multi-system disorder. It affects your blood cells, your hormonal glands, your immune system, your heart, your brain for sure, the blood elements, and I think it's, you know, more like asthma or diabetes. I mean, and it is the chronic, recurrent, progressive illness that is most common in young in life. So, you know, you get more years with it than you get with most illnesses. I mean, there's juvenile rheumatoid arthritis, but it's not common. I mean, depression is, you know, by your 20s, depression is already fairly common. So it's a big medical problem, social problem. I also like to take people off. The evidence for keeping people who have really bad depression on medicine is good, but I take people off.
Why?
If I can. I just don't like the unknown aspect. I just like to see whether, because I get away with it sometimes.
And what percent do you have to put back on meds?
A big percent. Big
Okay, sorry.
percent. A big percent. But some of them get good intervals off meds. And something else I discuss in the book is the whole notion of rescue. You know, whether it's better to keep people on prophylactically to prevent the next episode, or better to watch very closely and rescue, you know, vigorously.
Thank you.
Hi, that's actually a good segue to my question, which is the use of, or I don't know if it's growing, but I feel like with our growing elderly population, we baby boomers, we're all now talking about our parents instead of our kids, and there seems to be a lot of push for those who are elderly and maybe not in their top physical form or mental form anymore. They're getting depressed and they're being prescribed antidepressants. And I'm just wondering what you think about that, because, you know, these are not necessarily top candidates for therapy. Just sit down and chat. You know, they're not going to remember your name ever, or what they did yesterday.
Right. Yeah. Well, you know, the extremes of life are hard cases make bad law. I mean, with children, we don't know what we're doing. With the elderly, it's, you know, very hard to balance risks and benefits. But, you know, I think one reason doctors do it is they see occasional really good results. And by the way, and you and I have seen it. You know what I mean? They're just elderly people who all of a sudden are fretting less and going down to the dining hall and interacting with other people. And so sometimes it works, you know, very well, but you can get into trouble very easily also. And there are these concerns about falls, about bone fragility. There are all kinds of worries about antidepressants in the elderly. and any other medicine you're giving them. Plus, they're all, the kind of people you're describing may be on 8 medicines, and it's much harder to know what the 9th medicine is going to do.
I'm supposed to stop, but I'll take one more.
Okay. I go to school in rural Iowa, and there are literally no prescribers in my town, which is, like, it really, really sucks. So I was wondering, like, what do you do about this kind of access gap that I think isn't talked about as much?
Yeah. No, I don't know, but University of Iowa is so terrific that I'd be
Well, I'm at Grinnell, which is about an hour away.
I
from
know,
there.
but very surprised if they wouldn't Skype or G-chat, with you and or with a primary care doctor. But Grinnell must have a terrific mental health.
No, we can talk about this.
No, not terrific.
It's been
Maybe not.
A bit of a problem with that.
Yeah. But I think. Let me end on this in a different way, which doesn't solve the Grinnell problem, which is that, there's nothing like a good doctor. Forgetting the data. I was on one of the nationally syndicated public radio shows with a wonderful child psychologist, Maria Kovacs, who was talking about the evidence of these medicines working or not working in children. And the evidence isn't as bad as people think, but there's an article out lately sort of comparing them, and it looks like Prozac is the most effective, and some other ones are moderately effective. And she said, well, it doesn't matter what the data is, because if it's just important to work with a good child psychiatrist and a child psychologist, and that people will find answers to these problems. And of course, with children, they're failing, they're not meeting developmental milestones, they're suicidal before on it's really tough. And I do think that this is another theme of the book, really, that our doctors are better than they're getting press for, in the press. And that I kind of look at some studies that have been analyzed 2 ways, one in a way that's very skeptical about doctors, and one that is more generous in its assessment of doctors' workups before they prescribe. And I think my leaning again is to say we probably do have pretty good doctors. Our doctors are thoughtful, let me say that.
Cause for campus activism for you.
Yeah, I'm working on that.
Well, thank you all so much. Thanks for coming out tonight.
And by the way, thank you, Judy. This was so generous of you to do this, and the questions were so terrific. And yes, I should have said that. Yes, there are these wonderful self-advocacy groups on campus that I think can make an enormous difference.